Bismillahirrahmanirrahim. Today we will have case quiz number 62. Case data: 60 years old female, non-rheumatoid arthritis patient with symmetrical polyarthritis for 30 years. So the patient having symmetrical polyarthritis diagnosed as rheumatoid arthritis already 30 years ago. The patient had morning stiffness of more than 2 hours duration. For the past year, the patient has noticed papulonodular pruritic skin lesion. Papulonodular pruritic skin lesions over the scalp, trunk, extensor aspect of the elbow, dorsum of the hand, and ear pinna, with a history of spontaneous remissions and recurrence. So, in the last year, the patient has noticed papulonodular pruritic skin rash over the scalp, trunk, extensor aspect of the elbow, dorsum of the hand, and ear pinna, with period of spontaneous remission and recurrence. The patient is non-diabetes mellitus patient and is now managed by insulin therapy. On examination, the patient had mild pallor and brownish violaceous papulonodular lesions over the pinna, scalp, elbow, right forearm, and dorsum of the hands and on the back. A musculoskeletal system examination revealed synovitis of the knee, ankle, shoulder, elbow, wrist, MCB joint, BIB joints, MTB joints, but sparing DIB joints without any deformity. Other systems were unremarkable. Regarding the investigations, the patient had microcytic hypochromic anemia, shooting ESR 98 mm for the first hour. C-reactive protein value was also shooted 120 mg per liter. Positive rheumatoid factor and shooting or highly positive anti-CCP TIT over 200 unit per milliliter, but ANA was negative. The X-ray of both hands showed subchondral erosions of the wrist, BIB, and MCB joints, along with narrowing of these joint spaces with juxta-articular osteopenia, which are the typical features of rheumatoid arthritis. Histopathology of the skin nodules revealed diffuse histiocytic infiltration with occasional multinucleated giant cells, and it was stained positive for CD163 and CD68, but negative stained for S100. She was screened for an associated internal malignancy such as hematological breast, stomach, or cervix, but all were found to be negative. These are some figures of the case. Figure 1 showed papulonodular lesion over the left elbow. Figure 2 showed papulonodular lesion of the dorsum of the right hand, as you see in the yellow arrows. Figure 3, papulonodular lesion of the right ear pinna. Figure 4 shows X-ray of both hands, revealed subchondral erosion of the wrist, BIB, and MCB joints, along with narrowing of these joint spaces and juxta-articular osteopenia, as you see in the yellow arrows. These are the histology of the skin biopsy. Figure 5 shows sheets of histiocytic or histiocytes in the dermis and occasional multinucleated giant cells stained by hematoxylin and eosine with 10-fold magnification. Figure 6 shows CD163 diffuse positive staining. Figure 7 shows positive for CD68 staining. Figure 8 negative for S100 staining. Figure 9 show follow up after 6 months for the right ear pinna, and figure 10 follow up after 6 months of the hand. Both show moderate improvement. So, what is the diagnosis? The answer is yes. Multicentric reticulohistiocytosis or MRH syndrome. Multicentric reticulohistiocytosis. What is multicentric reticulohistiocytosis or MRH? MRH is a rare disease of unknown etiology with reddish-brown papules and nodules over the skin and the nasal and oropharyngeal mucosal surfaces associated with a destructive and erosive polyarthritis. You should remember that the disease itself may cause destructive and erosive polyarthritis similar to rheumatoid, but with some differences. The case was associated usually with fever and weight loss, which are common associations. MRH is also usually seen in the fourth decade of life with female predominance, fourth to fifth decade, which is younger than the age of our case. As we see before, the MRH may cause inflammatory and symmetrical arthritis, similar to rheumatoid arthritis. However, the association between MRH and true rheumatoid arthritis is very rare. You can differentiate the two cases. You have to differentiate the two cases. Is it MRH only with inflammatory and systemic and symmetrical arthritis, or it is MRH and rheumatoid arthritis at the same time, which is much less common? The most important thing is that the most common involvement of interphalangeal joints of the MRH syndrome is involving the DIB, distal interphalangeal joint, which account for 75% of the patient, which is never affected in rheumatoid arthritis. The symptoms of arthritis may wax and wane or rapidly progress to severe joint destruction, leading to arthritis mutilans. However, in our case, DIB is spared, giving a diagnosis clue of rheumatoid arthritis distinguishing mainly from psoriatic arthritis and MRH. In our case, we have no DIB involvement, and this was the clue that this case is rheumatoid plus MRH, not just MRH, and not psoriatic arthritis plus MRH. The skin involvement is a characteristic feature of MRH, and it may be the only feature of the disease. It is usually described as reddish-brown papulonodular non-pruritic or pruritic lesions that occur in isolation or clusters or crops with a cobblestone appearance. A thorough investigation should be conducted to exclude internal malignancies such as hematological breast, stomach, or cervix in patients with MRH because of a strong association between these malignancies and MRH. If there are only skin lesions but no arthritis, there is usually no association with cancer. So the cancer is usually expected when there are arthritis and skin involvement in the MRH. In our case, the patient has rheumatoid arthritis plus MRH. So we cannot exclude mainly that this is only affecting the skin and the joint is due to rheumatoid, because there is overlap between symptoms and we cannot be so confident with the results. The laboratory investigations should include elevated ESR, elevated CRP, anemia, lipid profile and rheumatoid factor, and anti-CCP antibodies. Imaging should include X-ray, MRI if possible, of the involved joint, skin or synovial tissue biopsy for MRH, which usually demonstrate multinucleated giant cells, mononuclear histiocytes containing periodic acid shift positive, eosinophilic ground glass cytoplasm. Regarding treatment, as few cases having combination of MRH and RA are reported, so the treatment continue to be experimental and include methotrexate, non-steroidal anti-inflammatory drugs, hydroxychloroquine, corticosteroid, and leflunomide, and may be, use biologics because there is no a strong clue to support or to support against. It has been shown that bisphosphonates such as alendronate and zoledronate are effective treatment for skin nodules as well as arthritis in MRH, suggesting that MRH may be a systemic osteoclastic disease. The key messages here are: coexistence of MRH with RA is very rare with few cases reported worldwide. Therefore, owing to its rarity, diagnosis can be challenging, and the most challenging part here is it MRH only with skin and articular involvement, or a combination of MRH and true rheumatoid arthritis case? Hence, clinicians need to have a high index of suspicion if the patient presents with erosive polyarthritis associated with papulonodular skin lesions. A definitive diagnosis of MRH rests upon histological examination of the biopsy specimen. And lastly, careful analysis of the clinical features are the keys to the early diagnosis of this disease. And finally, thank you very much for your attendance, and we will meet you inshallah tomorrow with case quiz number 63. Wassalamu alaikum wa rahmatullahi wa barakatuh.